Good evening, seniors, ladies and gentlemen. I'm very fortunate that we have this topic today because it's a very relevant and evergreen kind of a topic in our society with such a rampant number of tuberculosis, both pulmonary and extrapulmonary. So, without wasting much of time, I would like to invite the first speaker, Dr. Pradeep Suri, for his talk. Dr. Suri is an alumnus of Maulana Azad Medical College, where he did his graduation and post-graduation. And after that, he has done his MBA in healthcare from FMS Delhi. He's also done his lab management fellowship from IIM Ahmedabad, and he's been member of IPAC and International Union Against TB and LD. Also a member of Committee on Air Pollution. He's got fellowship in immunopathology from Germany. And today is going to talk about TB, and is aptly named his talk as Let's Talk TB. So I think we should let's talk and let's discuss TB today. Thank you, sir.
Thanks, Puneet, for the kind words. And I've named the talk Let's Talk TB, although the initial lecture was on lab diagnosis of tuberculosis, because I feel that TB is one disease which all of us face on a day-to-day basis, irrespective of our specialty. Whether we are in medicine, surgery, pediatrics, gynae-obs, or even super specialist branches, all of us encounter patients of tuberculosis at some point in time. And that's why I wanted it to be more interactive and everybody has something to say on tuberculosis. So with these words, I'll begin my talk. First, the WHO Global Tuberculosis Report 2016. The advent of the 21st century has seen nearly a 47% drop in TB death rates, and 43 million lives have been saved between 2000 and 2015 due to effective diagnosis and management. But in spite of all these, breakthroughs, it still ranks as a leading cause of deaths with 1.5 million TB deaths in the year 2015. So the incidence of TB was 9.6 million in 2015 globally, and 1.5 million people died with TB, including people who were HIV positive. The second big menace with tuberculosis is the emergence of drug-resistant tuberculosis. In 2015, an estimated 480,000 people suffered with multi-drug resistant tuberculosis or MDR, and there were approximately 190,000 deaths from it. So the global data shows that an average cure rate of only 50% is there for treated MDR cases. On top of that, XDR or extensive drug resistance has been reported in 105 countries. An estimated prevalence is 9.7% of all MDR cases also have XDR. The three biggest contributors to MDR-TB are India, China and Russia. Now the Indian scenario, we of course are the highest burden TB country, accounting for 23% of all global TB. The incidence of TB in India is 2.84 million as per the 2015 data. The annual deaths due to tuberculosis are 251,000. There is an added problem of HIV infection. 5% of all TB patients are co-infected with HIV. And MDR amongst notified new cases is 2.5%, whereas among notified retreatment cases is 16%. Now coming to the symptoms of tuberculosis, I don't think I need to tell the symptoms of tuberculosis to anybody. But the good thing is that Amitabh Bachchan also now knows the symptoms of tuberculosis, which can help in propagating it further. Next is chest radiography. So WHO clearly says that it is a screening tool but not a confirmatory tool. A classical picture of active tuberculosis is lesion in the upper lobe with or without cavitation, but even that is seen in other diseases as well. So chest X-ray is neither specific nor sensitive. You can have patients of TB without much findings on the chest X-ray. On the other hand, classical finding on the chest X-ray can be mimicked by some other diseases as well. So supplementation by microscopy, nucleic acid amplification or culture has to be done. So treatment of TB purely on basis of X-ray can result in significantly unnecessary treatment with adverse consequences in non-TB patients. So it is not one of the tools to diagnose TB, it's only a screening tool. Now coming to lab investigations of TB. Broadly, they can be put under 7 heads. The first two tests, the tuberculin skin test and interferon gamma release assay or IGRA, are primarily used for latent tubercular infection or you can address them as LTBI also. The other tests, including microscopy, culture, NATs, phenotypic, genotypic, drug susceptibility testing, and ADA, are primarily used in diagnosis of tuberculosis as well as diagnosis of MDR as well as XDR. Smear microscopy can be done using both modified Zeal-Nielsen staining as well as fluorescence staining. Culture can be done using solid cultures, agar cultures, or the rapid liquid cultures as we do them today. NAT testing includes PCR, AMTD, GeneXpert, NASPA, etc. But the only NAT test that has got WHO endorsement till date is the GeneXpert. Then we have the phenotypic and genotypic DST for diagnosis of MDR and XDR tuberculosis, primarily from Hain Life Sciences. And ADA, of course, is a useful tool, especially in tuberculosis fluids, pleural, peritoneal, and CSF fluids. This is the timeline of the technologies that have been endorsed by WHO. In 2007, the first technology that was endorsed by WHO is the liquid culture or the rapid culture using BACTLERT or BACTEC and drug susceptibility testing tools. In 2008, the molecular line probe assay from Hain first line drug susceptibility were approved for rifampicin and isoniazid. In 2010, we saw two new technologies getting endorsement. One is the LED microscopy using fluorescent auramine stain, and other is the GeneXpert for the diagnosis of pulmonary tuberculosis. In 2013, the policy recommendation was extended for childhood as well as extrapulmonary tuberculosis, and the indications in various extrapulmonary cases was also included in the WHO guidelines. And the last test to be endorsed is this molecular LPA for second line anti-tubercular drug susceptibility, including fluoroquinolones and aminoglycosides. Now this is interesting. The line probe assay for both first and second line were introduced in 2008. But the second line took 8 years for that endorsement, primarily because of ethambutol. Ethambutol has low sensitivity, and that is why WHO was not endorsing it for 8 years. So now they finally removed ethambutol from the second line again. Coming to the test for latent tubercular infection, the first and the most common test is the tuberculin skin test, or what we know as Montux. It is the only universally accepted test for the diagnosis of LTBI, but this test comes with many limitations. A, it is false positive both in cases of cross-reactivity to MOTS as well as to vaccination with BCG, and sometimes even BCG given as a cancer chemotherapy also. Also, there is poor sensitization in immunocompromised patients and up to 10 weeks after infection with mycobacterium. The exact sensitivity and specificity of TST can never be known because there is no reference standard. It is further limited by its subjectivity of its interpretation. Inter and intra-reader reliability, return visit is needed, and last but not the least, it cannot distinguish between LTBI and active disease. So this is a big limitation with this test. The next we have is the interferon gamma release assays, or what we know as IGRA. In this country, primarily we know them as TB Gold. Although there is another test that is US FDA approved called T-Spot test, which is not available in India. So there are only two IGRAs that have got US FDA approval and the approval of CDC Atlanta and IDSA. One is TB Gold and the other is T-Spot test. Both these tests rely on detection in serum of release of interferon gamma, on stimulation of sensitized T cells by antigens in vitro, or in the case of T-Spot, detection of T cells themselves. The good thing is they are not influenced by BCG vaccinations, and also they don't cross-react with most MOTS, barring 3 MOTS, Kansasi, Marinum and Zulgai. IGRAs cannot distinguish between latent and active disease like Montux, but the use of IGRA as a replacement for TST would decrease the number of LTBI suspects to be investigated for active disease by approximately 70%. Limitations of IGRA, first is the same as Montux, cannot distinguish LTBI from active disease. Again, point after infection at which antigen becomes detectable is not known. And performance in small children, immunocompromised patients is again suspect. And last but not the least, it is not a tool to monitor response to treatment. Some people try to do IGRA pre and post treatment to look for falling titers. there is no bearing on IGRA in response to treatment. So these are the antigens with which IGRA cross-react. As you can see, it does not cross-react with the BCG strain and most of the mods, barring Kansasi, Marinum and Zulgai. But it reacts very well with the MTB complex, tuberculosis africanum and bovis. So now the latest CDC IDSA guidelines 2017, when to go for IGRA and when to go for Montux. So they recommend that diagnostic testing for LTBI are based upon two things: A, likelihood of infection and likelihood of progression. So they recommend IGRA in comparison to TST in the following settings: in individuals who are 5 years or older and who meet the criteria. A, they are likely to be infected with Mycobacterium. B, they have a low to intermediate risk of disease progression. C, it has been decided that testing for LTBI is warranted. And fourth, either have a history of BCG vaccination or are unlikely to return. So they are not sure whether they'll come back to get the reading done. A TST is an acceptable alternative, especially in situations where IGRA is not available, too costly or too burdensome. So now we are in a fix. India is a 100% BCG vaccinated country, so there will be cross reactivity with Montux. But again, we are a resource scarce country and IGRA is both too costly as well as too burdensome. So when to use IGRA and when to use Montux is a slightly tricky issue in Indian settings. My personal take is that if a patient can afford it, then you should go for IGRA. These criteria are meant for suggestion only. Local tuberculosis control units should be consulted for local guidelines. There is insufficient data to recommend a preference for either TST or IGRA in individuals who are 5 years or older who are likely to be infected with TB and who have a high risk of progression to the disease, and in whom it has been determined that diagnostic testing for LTBI is warranted. And the guidelines recommend that persons with low risk of MTB and disease progression should not be tested for MTB infection. While both IGRA and TST testing provide evidence for infection with tuberculosis, they cannot distinguish active from latent. Therefore, diagnosis of active disease must always be excluded before embarking on the chemoprophylaxis for LTBI. Now the interesting question comes that who is low risk and who is high risk, and second, who is at a higher risk of disease progression. So they are given this table that at the top of the table are household contacts of recent exposure to active disease. They are at the highest risk of contracting tuberculosis. Then mycobacteriology laboratory personnel. Then immigrants, we are pretty much all in this category. And residents and employees of high risk congregate settings. And for disease progression, there is an intermediate relative risk of 1.3 to 3 in patients of diabetes, in patients of chronic renal failure, and in patients of intravenous drug use. But so far, prophylaxis has not been warranted for this group. The group where prophylaxis has been warranted is children less than 5 years, patients with HIV co-infection, patients of immunosuppressive therapy, patients of abnormal chest X-ray consistent with prior tuberculosis, and patients of silicosis. In this group, the chemoprophylaxis is warranted. And just to summarize the three groups, TST is preferred in a group where it is likely to be infected and high risk of progression, and where likely to be infected, low to intermediate risk of progression, IGRA is preferred, and where unlikely to be infected, you don't test at all. This is the WHO algorithm for latent tuberculosis infection. So basically WHO says that look for 6 categories of patients. Patients with HIV infection, contact of pulmonary tuberculosis, patients who are initiating TNF-alpha therapy for rheumatoid arthritis management, patients on dialysis, patients preparing for organ or hematological transplantation, and patients with silicosis. If the answer to your first question is yes, then you ask the second question, that does the individual has any symptom of tuberculosis? If the answer is yes, you investigate for the active disease. If no, then you do TST or IGRA, but let me tell you, in all these settings, most rheumatologists and nephrologists are doing both of them. So any positive, they are taking it as positive. And if it is positive, then you do a chest X-ray. If abnormality, then again work for active disease. And if no abnormality, then treat for LTBI, chemoprophylactic regimes. Now coming to the test for tubercular disease. First test is the AFB smear or microscopy. This is the most common and most widely used test for detection of tuberculosis, done by both the methodologies using conventional microscope and modified Zeil-Nielsen stain, or fluorescent microscope and Oraming stain. This not only establishes diagnosis but also establishes infectiousness, the ability of the patient to transmit the disease to the other patient. So the advantages of microscopy are pretty apparent. It is cheap, it is rapid, and it is relatively specific. I am not saying it is very specific, but it is relatively specific. The disadvantages are, A, it is subjective. In an ideal scenario, we need to see at least 100 to 200 fields. There could be issues of, diligence, and sometimes when technicians are seeing, there could also be issues of competence to detect AFB on smear examination. It is less sensitive compared to culture. The sensitivity is 40 to 60%. It requires a high bacillary load as a limit of detection. The LOD is 5 to 10,000 CFU per ml. And the latest WHO says that you don't require 3 sputa, you require only 2 sputa. The reason being that the third sputa only adds 1 to 2% to the sensitivity. So in the cost benefit analysis, there is no rationale of doing 3 sputa examination. So 2 sputa are sufficient. Fluorescent microscopy is more sensitive than conventional by about 10%, and concentrated specimen either by centrifugation or by taking early morning specimen can also increase the sensitivity. It can be false positive in certain organisms, Nocardia, Gordoniella, Legionella, bacterial endospores, Rhodococcus, and some moths where this can be positive. The most important thing is that a negative smear does not eliminate the diagnosis of active tuberculosis. In fact, this line holds true for the culture and the molecular as well. Basically, there are no rule-out tests for tuberculosis. All the tests for tuberculosis are only rule-in tests. This is the RNTCP grading system in which we grade the AFB smear from negative to scant to 1+, 2+, 3+, based on the number of AFB that we see per oil field. This is not only of academic interest, this is important from a clinical perspective as well, because usually patients with these grade 2 and grade 3 are more likely to be resistant to therapy, are more likely to respond late to therapy, which means that you must give a longer initial intensive phase of therapy with patients who are 2+ and 3+ on grade. So grading of tuberculosis is important from both prognostic and management point of view also. Next we have AFB culture. This till date is the gold standard for diagnosis of tuberculosis. It can be used for confirmation of microscopy, for treatment failure, for relapse, for monitoring MDR, XDR cases, for identification of mycobacterium variants for epidemiological purposes. It is more sensitive than microscopy. As you can see, this LOD is up to 100 viable organisms per ml of specimen. So till date it is the most sensitive assay available to diagnose tuberculosis. So again we have 3 kinds of culture. The egg based or the conventional LJ media, where you can get a growth in about 6 to 8 weeks. Then we have agar based Middlebrook 7H10 and 7H11 media, where the growth is a little faster, 3 to 4 weeks. And then we have the rapid culture or the liquid media using Middlebrook 7H12 and 13. These can yield result in 2 to 3 weeks. Having said that, the number of weeks is basically dependent on the bacillary load. So the more paucibacillary the sample, the later the growth will appear. So even with liquid media, I have sometimes reported in 5 to 6 weeks as well. The advantages of a culture are that it is very sensitive, 80 to 90%, and very specific, 98 to 100%. It can also be used for drug susceptibility testing or phenotypic DST, as well as for characterization of species. Limitation is that it still requires characterization of species because even moth can grow in culture specimens. And it is very slow, takes some weeks. This is the basically bone of contention with AFB culture. Even with the liquid culture, it is still pretty slow. So this is the bacterial bottle, as you can see it. rapid culture using Middlebrook 7H1213 media. Basically, it utilizes the Krebs cycle principle of bacteria. The bacteria produces carbon dioxide, reacts with water, and then they split up into H plus and HCO3 minus ions, which causes a change in pH, which is detected by a color change at the colorimetric sensor. This is the overview of the machine. On the right is a controller module, which takes care of the loading and unloading of the bottles. And these are 4 incubator modules. Each module has about 60 bottles. This can be customized for blood culture as well. The same machine can be used for both blood and TB culture. This is the colorimetric sensor. So the green color converts to yellow. So yellow color is the positivity of the bottle. So actually you get the growth before you actually see the colonies. Because of the emission of CO2, the color changes before the final appearance of the colonies. Now this is the results recovery compared to the LJ media. As you can see, the sensitivity for Mycobacterium tuberculosis species is 98.4% on Bacillus, whereas it is 90.4% on LJ media. So the sensitivity is about 8% better on a liquid culture. But when you move to MOD, the sensitivity is even further better, maybe 10 to 15% better for some MOD species. Now this is the phenotypic DST protocol. So suppose a bottle has turned positive. What we do is we make a 1:100 dilution of that broth and we inject 0.5 ml of it. This is the 1% growth control. So this acts like a cutoff control for the various antibiotics. Here I have taken the first line antibiotic rifampicin, INH, streptomycin and ethambutol at the desired concentration. And then we inject all the 5 bottles back into the machine. So if the growth occurs before the 1% growth control, it is resistant to that antibiotic. If it occurs later, it is susceptible. Even if it occurs on the same day, you should consider it as resistant. This is the comparison to the other competitor, Bactec 460. Both of them are WHO endorsed. As you can see, for INH, rifampicin and streptomycin, there are good agreements, both in terms of sensitivity and resistance. You can see they are 99, 100, 197%. Ethambutol creates a problem. If you use 1 microgram cutoff, the sensitivity agreement is lower, 77%. If you use 2 microgram cutoff, the specificity agreement is kind of little lower, 80%. Ethambutol has been a problematic even for genotypic DST. That is one of the main reasons why Hain Life Sciences have removed ethambutol from their second line DST. Pyrazinamide again has better correlation for resistance, mediocre correlation for about susceptibility. Now coming to the molecular diagnostic techniques. These are the latest techniques which include AMTD and PCR. AMTD is basically based on RNA amplification, whereas PCR is based on DNA amplification. Both are good technologies, both are state-of-the-art technologies. The advantages are A, they are rapid, you can have a result in a few hours. They are both highly sensitive and specific, and the limit of detection is also low, 100 to 155 or 150 bacilli. So they kind of, create a best of both the worlds between a smear and a culture. They are as fast as a smear and almost as accurate as a culture. The disadvantages are that they are still expensive and they require expertise. So why do we need amplification firstly? Because direct detection with probes is not possible, so I need to amplify that product. Microscopic smears are rapid but insensitive. Culture is both sensitive and specific, but it is too slow. This is the first days of the homemade PCR. We used to have these manual extraction systems. This is the thermal cycler, in which there was amplification, and then there was migration and revelation on the gel dock. So there was divided into 3 steps in 2 to 3 rooms with negative and positive pressure rooms, and it used to take nearly the whole day to do the whole thing, and it also had a problem of contamination. So when contamination occurs, you could have false positive results as well. Then came the next generation real-time PCR, in which the amplification and detection was combined into the single machine, but the extraction was still manual. This is what we have today, GeneXpert. These are different modules ranging in size from 1 test to about 80 tests based on the throughput of the modules. This has been a really revolutionary technology because